All right, you're good.
All right. Hey, well, thanks everybody for coming out to Journal Club today. And it's great to have Dr. Foster and Dr. Cowgill on since they are authors on this paper. You know, for about the first, since I've been doing dialysis since about 2016, but I never have done IHD until about the past 3 or 4 months now. So, I never really had a big knowledge of the dialysate sodium other than what came in the bag of Prismasol that I was using, and varying it wasn't an option, obviously. So when I started learning about IHD and that you could vary the sodium of the dialysate, and really that there was this number, this magic number that you added to what you wanted your final patient sodium to be, it was interesting to read this paper and find out where a lot of that came from. So for those of us who do dialysis, we know, or those who don't, there's a lot of abnormalities in sodium and water balance that occur frequently in dogs having hemodialysis, and it could range from hyponatremia to hypernatremia, and of course water balances to being dehydrated, or how we find them frequently to be hypervolemic. And as you're doing the therapy, the patient's plasma sodium is going to equilibrate with the dialysis sodium over that therapy time. So that does provide a window, of therapeutic adjustment for the patient, where during your session you can adjust their or maintain their sodium as you think proper. And also this concept that if you leave a positive dialysis to patient sodium gradient, if that's what you're leaving the patient with, it could have side effects such as increased intradialytic thirst, water accumulation, and associated hypertension and cardiovascular disease. It seems that hyperkalemia can evolve from that positive gradient, and it's definitely known in people to increase morbidity and mortality in end-stage renal disease. So as far as the goal for dialysate sodium over a hemodialysis therapy, it's usually to either correct to or maintain normal sodium. And we still try to target that to be less than about half a milliequivalent per hour change in plasma sodium. Although I guess because we're changing osmolality in other ways at the same time doing dialysis, that it might not apply quite as stringently as it does when we are doing routine fluid therapy. The dialysis sodium can also aid us in ultrafiltration, can help reduce the occurrence of dialysis disequilibrium, and can aid in the management of hypotension that might be occurring during your dialysis session. So really, before this paper was published, the effect of the dialysis sodium on a dog's plasma sodium was unknown. And so the purpose of this study then was a retrospective review comparing the dialysis sodium with both the pre-dialysis and the post-dialysis plasma sodium in dogs receiving intermittent hemodialysis. And a secondary objective was to identify factors that may help improve the use of the dialysis sodium to avoid development of dysnitremias secondary to our therapies. The materials and methods, the medical records from both University of Pennsylvania and UC Davis from October 1st, 2009 to April 1st, 2014 were reviewed. They were looking for dogs that were receiving intermittent hemodialysis and had reviewing those records. The dialysis sodium was predicted by the programmed dialysis conductivity of the Phoenix machine, and the plasma sodium before and immediately after each treatment was needed to be included in the records for them to qualify. They were excluded if they had to receive IV fluids or sodium profiling, or if the sodium was not measured by direct potentiometry. Statistical analysis was by Spearman rank correlation between the DNA and PNA, and linear regression analysis was used to determine correlations, the best fit, and the values were significant to a p-value of less than or equal to 0.5. So significant correlations were found in each of the groups that were looked at. The one with the most significant correlation was the gradient, the DNA to PNA gradient when compared to the change in plasma sodium over the course of the therapy. But there was still a level of significance for the dialysis sodium and post-dialysis plasma sodium, and then the pre-dialysis gradient and the post-dialysis gradient had the weakest correlation, but was still significant. Here's the graph associated with the pre-dialysis sodium to potassium gradient, had that strongest correlation with an R-squared value of 0.72. And the regression line could be predicted by that formula, the change in plasma sodium that you see on the bottom. This is where the idea that the gradient needs to be about 8 came in, because as you can see on this graph, that's where the line crosses for isonatricity. If you were not having any change in the dialysis sodium, in the patient's sodium over the course of the therapy. The dialysis sodium was moderately correlated to the post-dialysis plasma sodium, with an R-squared value of 0.5. Again, less correlated than the pre-dialysis gradient. And you can see here on the graph that, although there is an okay fit of that line, dogs, for instance, treated with a DNA of 100, dialysis sodium of 151 could range from 134 to 149 when they were coming off the machine. So it wasn't quite as good a correlation. And finally, again, here's the graph of the pre-dialysis gradient and the post-dialysis gradient, which did have the weakest of the 3 correlations. So again, this idea of what do you need to do to maintain isonatricity? It seems that in a dog, the dialysis sodium should be about 7.9 millimoles per liter greater than the pre-dialysis sodium to maintain isonatricity, which is contrasted to that in people who actually need a negative DNA to PNA gradient to achieve isonatricity. And I guess in people, the dialysis sodium is usually set either slightly less or about the same as the pre-dialysis patient sodium. And really, the reason why dogs have this difference in humans is not completely known. One idea of what could have affected some of those measurements was that mannitol was administered to approximately 15% of the treatments. Timing in relation to collection of the blood for sodium measurement of the mannitol was really not known from going through the records. So you couldn't know that it wasn't administered right close to the time that we were going to draw that sodium of the animal coming off the machine. So if administered near the end of a session, it could potentially decrease the post-dialysis plasma sodium. Mannitol, it works by being hypertonic and creating a drive for fluid movement, and it results of movement of intracellular water into the intravascular space. And, one of the comments was in the article was that this effect is reported to be of short duration, so that, potentially, unless it was given very close to the end of therapy, that likely it would have been removed by the dialysis membrane with its molecular weight of 182 Daltons. Though there was theories that potentially the difference in patient populations could have resulted in that gradient difference to maintain isonatricity, because as we see here, the reference range for sodium in humans is lower than that it is for dogs, and albumin too. Humans seem to have a higher albumin reference range than our dogs do. And there is this Gibbs-Donnan effect then that is, has to do with ions and that are able to move through membranes and large bulky proteins that are charged that aren't. So there usually is an unequal distribution of permeable charged ions on either side of a semi-permeable membrane, which occurs in the presence of impermeable charged proteins. So the small cations might be attracted to that protein, while the small anions are going to move away from that protein. And this potentially could explain some of that gradient difference, given the differences in reference range of sodium and albumin in humans and dogs. So it's unknown, though, if the population differences in sodium and albumin would lead to interspecies differences in Gibbs-Donnan equilibrium. But again, that might have explained this if possible. Another population difference here is that data regarding the relationships of dialysis sodium and plasma sodium in humans are from patients that are undergoing chronic maintenance hemodialysis. And, they had probably been doing it for months, which allowed them to establish a steady state plasma sodium over that time period, which in the dogs that we dialyze, very infrequently are they getting chronic therapy. I think the median therapy number of therapies was 4 for the dogs on this study, and the range did go up to 51, so someone was getting chronic therapy, but it doesn't seem like any of the majority of the dogs were not. So they likely did not ever have a chance to reach a steady state with their plasma sodium over the courses of their therapies, and this also could affect that gradient. I did want to mention sodium modeling a little bit here too, since the paper mentioned it. And it is, it's where you change the dialysate sodium over the course of a treatment. And again, this study didn't look at animals that received sodium modeling, but because it would have, made it harder to interpret that data. But it can be either balanced or unbalanced. And balanced means that the sodium that you start at is the same as the sodium that you come off the machine at. And unbalanced is when the sodium, I guess, would either be lower or higher usually than the one that you started with pre-dialysis. Numerous strategies are used for sodium modeling. You can see here in this graph, there's a linear model, there's a stepwise model, which is the ones that I'm most familiar being taught about, and there is an exponential model there. You can use a low to high approach, meaning starting your sodium low and working up to a higher sodium to prevent dialysis disequilibrium and its syndrome. It also can be given in a high to low fashion to help prevent hypotension in patients that are prone to it when receiving hemodialysis. And you can also use it to help achieve ultrafiltration goals that you might have by modeling the ultrafiltration with your higher sodiums. Again, though, back to this idea of leaving an unbalanced sodium modeling where you might leave excess amounts of sodium in your patient. Again, that's going to lead to volume expansion, which you technically could, again, remove with ultrafiltration kind of chasing what you were doing. And just again, we like I stated earlier, it's known to contribute to morbidity and mortality with interdialytic weight gain, hypertension, cardiovascular disease, hyperkalemia, and it sets you up to have increased ultrafiltration needs the next time you see the patient for therapy. Interesting, the concept of sodium homeostasis. There's a balance between dietary sources and internal metabolism, as well as losses from either the gut, kidney, or the hemodialyzer. And traditionally, we were all kind of taught this two-compartmental model of sodium, which really now has been replaced by one that describes three, where there are storages of sodium in the skin and muscle interstitium that is free of water and osmotically inactive sodium. So you have that, osmotically active sodium that we all know about in the extracellular space, a slowly exchangeable pool in the bones, and then this new concept of water-free storage in the skin and muscle interstitium. And they've documented increased elongation and sulfation of skin glycosaminoglycans that occurred in experimentally induced sodium storage. And the thought was that the interaction between negatively charged glycosaminoglycans and sodium may lead to these osmotically inactive sodium storage in the skin to occur as it's known to in cartilages. And since that kind of theory has been around, it has finally been confirmed with both skin biopsies and something known as sodium MRI, where you can look into the sodium content of tissues with MRI. Again, the sodium complex in the skin is osmotically inactive, and its quantity in a way modulates the plasma sodium. And the skin deposition will occur until it's saturated without a substantial increase in plasma osmolality. It seems like it's acting as a buffer for it. And the net transfer of sodium, so this idea makes it quite obvious that the net transfer of sodium is more complex than just the difference between pre and post dialysis sodium. Some limitations of the study included dogs were allowed to receive food and water through an esophagostomy tube during the treatments. And there was a great variation in the volume being fed, the water content, and the sodium contents of those diets. And so, it was hard to quantify that for inclusion in the study. And that also, I guess, would further display some patient population differences in that, certainly humans most likely are not getting fed through an esophagostomy tube. I assume that they can eat during dialysis, but it is a difference. Another limitation of the study was that bioimpedance spectroscopy was not available for most of the treatments. This unit on the right there is a veterinary available bioimpedance spectroscopy unit that you could use to help you predict extracellular fluid volume, intracellular fluid volume, total body weight, fat-free mass, percent body fat, and body cell mass. And the machine allows for serial evaluations of body compartmental interactions in a real-time and non-invasive manner. The way that this works is it measures the resistance to the passage of a current through an ion filled or a conducting filled cylinder if you're using it in a manufacturing or in a chemical setting, or in a human tissues or dog tissues. The dog could be considered the cylinder. If the current and the voltage are known, then the resistance can be calculated, and the resistance to the passage of the current is inversely proportional to the volume, and that way the volume can be deciphered. Dr. Cowgill lent me this slide, and it shows this multi-frequency bioimpedance spectroscopy, where you use different frequencies to determine the intracellular and extracellular fluid volumes, really the intracellular fluid volume and the total body water. You can see that, I guess, a low frequency current is best for estimating the extracellular fluid volume. And it has something to do with the fact that the lipid in the cell membrane does not allow passage of that low frequency current. So it represents the extracellular fluid volume when you use it. And then in the same token, when you pass a very high frequency current through the cell or through the dog, it can estimate the total body water then, because it will penetrate through those cells. And then you can use a calculation to get the intracellular fluid. When performed in real time during an HD session, the bioimpedance can be very helpful in predicting things like dialysis disequilibrium, which this graph does show in where with a big expansion of the intracellular fluid volume during a patient receiving hemodialysis with ultrafiltration. It can also help detect mismatches in dialysis sodium with patient sodium. Let's say you were giving a dialysis sodium that was much higher than you needed to give. Well, you might see the opposite of this curve, where the intracellular fluid volume is contracting while the extracellular fluid volume is expanding through that dialysis, the increased dialysis sodium. And I guess it can also be very helpful in monitoring nutritional status, as that intracellular fluid really represents the lean body mass. And when you have a patient receiving chronic hemodialysis, you could let that help you. Increasing ICF might help you know that you are increasing lean body mass and meeting that patient's nutritional needs. Another potential limitation of the study was that the dialysis sodium was not measured. It was predicted on the basis of the programmed dialysate conductivity. And the Phoenix has a range of sodium that it can make in its dialysate from 132 up to 170. And I guess this is set by altering the conductivity of the dialysate. And you can see this graph is from the manual of the Phoenix, and then Dr. Foster made a regression equation for it that shows you how the conductivity relates to the final sodium value in the dialysate. And so, again, the conductivity is the amount of electricity that is conducted through the dialysate, and it's based upon the electrolyte concentration. And the higher the electrolyte concentration, the higher the conductivity will be. So limitations in measuring sodium make, this measuring sodium by direct potentiometry, if you can't do that continuously. I guess these are single-use types of measurements, where if you use a current and follow the conductivity instead, you can make an infinite number of measurements and follow that dialysate sodium, making it a much more convenient way, a surrogate for the sodium being a more convenient way to measure it. And, based upon a study way back from 1993, dialysate conductivity is reported to be an accurate predictor of the dialysate sodium. So in summary then, the dialysate sodium was correlated to the patient sodium, and using the pre-dialysis sodium to patient gradient enhances that correlation. Prospective studies are needed to validate the findings of this study and their utility in predicting post-dialysis plasma sodium. And this could be performed across various hemodialysis treatments, machines, and platforms to really get a better idea of how sodium is affected. Each patient's dialysis sodium should be individually formulated on the base of their pre-dialysis patient sodium. And if you have the ability to use it, bioimpedance spectroscopy may be useful in providing further information about sodium and water movement during hemodialysis. I think that's what I have for you guys today, and I really enjoyed this study and would love to hear what anybody has to say about it as well.
Thanks, Seth. That was a really nice and very kind review of our manuscript. I really appreciate that. One question that I have based upon this work that we did is, what is the influence of the individual? Because when you look at that figure, even the figure that showed the best correlation between the initial gradient and change in sodium, pardon me, if you set the dialysate about 8 points higher than your patient sodium concentration, on average, most will come off with no change, but some will come off higher and some will come off lower. That regression line is not perfect. It's like, what, 0.7, somewhere around there. But I wonder how each individual factors, because you point out a lot of the things that we were worried about. Oh, yeah, perfect, this one. Yeah, so if you look at right where this regression line crosses that 8 points, you can see that there are some patients that are still coming off 5 points higher, some patients that are coming off 5 points lower for what their serum sodium concentration might be. And so, how do I use this? I'll use this to start with. I'll use this kind of 8 points as my predictive place when I'm trying to design my dialysate sodium for IHD. But if I find that my patient is coming off lower or higher than that, I might not stick so much with that 8 points. If I set them 8 points higher and their sodium comes off 3 points higher than where they started or where I wanted them to intend to, then the next treatment, I might actually only set their dialysate sodium maybe 5 points higher. And to be honest, I don't know enough from an objective standpoint to look back and see, does that improve my outcomes to maintain isonatricity? Meaning, can I account for the individual variability, or does the situation change? Are they responding differently on treatment number 1 than treatment number 2? And as you mentioned, because they're AKI, they're just so much more dynamic. So I don't know. That's just a question that I still have that I don't think we answered, or we really even attempted to look at, is, are there patients that are just consistent? And if your patient's coming off, if you set the dialysate 8 points higher and they're always gaining sodium, can you then dial things in there? My clinical impression is I think that that's more likely the case, but it'd be nice to have some data to show that.
Yeah. I would agree with you as well. And it might have to do with these individual variations, could be individual variations in their albumin concentration or their proteins, or a million different things. I was flabbergasted when we had always just by observation knew that we needed to have a dialysate sodium that was 4 or 5 millimolar higher than the starting serum sodium in order to have the patient come off at the sodium concentration that they started with. And I was shocked when the graph showed that it was 8, because we would almost never use 8. But you do have to kind of predict 4 or 5 higher on almost all patients, and so maybe that floats around the range here that we see. I guess that was one point that I wanted to make. And the other point is you do see a lot of, if you and we worried about this a lot because we used to do a lot of sodium modeling in the old days, and we worried very much about the hypernatremia, the hyperkalemia that would occur at the next treatment. And so that can be a real thing. If you end up with these patients being hypernatremic at the end of the treatment, very often you'll exacerbate their potassium redistribution as they pull fluid out of the intracellular compartment. It drags potassium with it, and you can end up with a much higher serum potassium at the next dialysis session. So
I was wondering if that also had
Thanks,
to do with it being concentrated. To give higher sodium, is the potassium more concentrated in your acid bath too?
No,
No.
it might even be diluted. The potassium that occurs when you if you programmed a higher sodium concentration, probably you're going to get a slightly lower dialysate potassium concentration than maybe what the jug says because of the changes in the conductivity. But if you leave the patient with a high serum sodium at the end of the treatment, then you've got a gradient, an osmotic gradient across the cell membrane. It's kind of reverse disequilibrium. Water's going to shift out of the cells. And when the water shifts out of the cells, it drags potassium with it because that's the major cation inside the cells. So you get a more exaggerated potassium rebound if they end up with a high sodium at the end of the treatment.
But what Seth said is correct. If you set your dialysate sodium to 150, that jug of concentrate that says the potassium will be 3.0, if you look at the print on the front of that, it says at a dialysate sodium of maybe 135, maybe 138. So if you set it to 150, it will become 150 by not diluting out the concentrate as much. So everything does incrementally increase. I don't think it's going to be clinically significant, and you can work out the math, but it might mean that 3K actually ends up being maybe 3.1K, maybe 3.15K. It's not going to be a huge difference. But yes, the higher you set your sodium to of your dialysate for systems that are proportioning using a concentrated electrolyte solution, all the other electrolytes that are present in that jug are going to be there in a higher concentration as well too. The effects will be smaller with pretty much everything else because sodium and glucose are probably the most prevalent molecules in that solution, period. But yeah, Seth, you are right that if you set it to 150, your dialysate potassium won't be 3K, it'll be like 3.1K or something along that line. Like we'd have to work out the math, but it will be somewhat higher.
Yeah, and I'm sure it could still drag enough water in there to dilute it out at the end. Like what Dr. Cowgill was mentioning.
Well, the rebound is not thought to be changes that occur during the treatment. They're changes that occur during the rebound period, and that's from water shifts out of the cells, at least for potassium. It is helpful though. I mean, I think we don't manipulate the sodium. The practice in human patients was they used to use a low sodium dialysate concentration to try to obviate the hypertension that occurred in these people, and that turned out not to be a good effect. And it has been anecdotally helpful, I think, in patients that we are highly suspect of dialysis disequilibrium syndrome, and certainly sometimes when you've got a patient that you just can't get the fluid off. And it always perplexed me, particularly when we were doing bioimpedance on this. We would see that we'd raise the dialysate sodium, and it would look like their their fluid compartments were increasing, but when you weighed the patient at the end of the treatment, they lost the amount of weight that you had programmed by ultrafiltration. So there's some kind of voodoo that's going on when you start playing with the sodium concentration in the dialysate.
All right, that was great. I really appreciate everybody's input on that.
Maybe I'll make one more point, because this is something that we see fairly routinely. Most of the time, you're not going to know what the sodium concentration is at the start of your dialysis treatment. I mean, that's a number that if you even do a pre-dialysis sodium measurement, it's not probably going to come to you until later in the treatment. And if you're doing crit line measurements on your patient, you see this massive increase in intravascular volume during the start of the treatment. Usually that's because there's been a huge mismatch between what the patient's starting sodium concentration was and what you set the dialysate sodium concentration to. So if you see those gigantic changes in blood volume during early treatment, very often you've overshot the sodium concentration that you were targeting for that patient as an unknown when you started the treatment.
Okay, guys. Well, thanks for joining. I guess I'll wrap it up and see you next week.
Thank you so much.
Take care.
Thank you, Seth.
Thank you.
Thanks, Seth.